We're going to turn a little bit to our work here at the 180 Center. We have seen in studies, have shown, and we've seen in our own work that trauma is almost always at the core of chronic relapse in addicts. Why do you feel, or how do you feel, EMDR is an effective modality for treating trauma, specifically in addicts?
Well, I think this is a really important question. And first, I just want to say that it's really a privilege to be associated with the 180 Center. I've worked with you, Steve, and with Bernie Freed since even before you founded the 180 Center, and have consulted on some of your other cases before. It isn't just a feeling or a clinical observation that trauma is commonly involved with substance abuse problems. The SAMHSA, Substance Abuse and Mental Health Services Administration research shows that the vast majority of people with alcohol and other substance abuse problems have co-occurring disorders. Most commonly trauma-related disorders. Trauma typically leads to symptoms of post-traumatic stress disorder, but it can also cause other anxiety disorders and other depressive disorders. And the vast majority of people with these co-occurring disorders do not receive treatment for both their substance abuse problem and their other co-occurring conditions, which is why most treatment programs have high relapse rates. If you don't treat the co-occurring condition, then the person's going to continue to have a need to medicate. And if their prescription medications don't meet their needs adequately, they're going to begin to self-medicate again. So relapse rates are very high if you can't resolve this. And PTSD in particular has an episodic cycle. People alternate between phases of intrusion and phases of numbing. So people can have a quiescent phase where their intrusions are somewhat hidden, and then as they get triggered, their intrusions become reactivated, they start to have urges to relapse again. It isn't just a chemical process of detoxification. It's the condition association between a long-established history of self-medication in response to the cyclic return of the trauma material. And the trauma material, as Bessel van der Kolk has pointed out, is not that often in the form of disturbing images or nightmares and the kind of overt signs of PTSD that many clinicians might be looking for. The most common forms of the reoccurrence of trauma symptoms are body sensations and emotional states that are the re-experiencing of aspects of traumatic experiences. And so clinicians who don't have a strong background in psychotraumatology won't recognize that the cues that are triggering relapse are associated with traumatic experiences. They won't have gone looking for the trauma history. They'll be thinking that that's too disruptive to the client who's in a recovery program to uncover that material, and they won't even think about treating it. And so as a result, these co-occurring conditions largely go untreated. And so what you're doing here at the 180 Center, I think, is really pioneering work. I think you're one of a handful of programs around the country that's even thinking about attempting to use a comprehensive approach. And I know that you do more than just conventional recovery work and EMDR here. You use lens neurofeedback and other innovative approaches to try to get at the source of what's going on behind the urge to use. But EMDR is an essential part of a comprehensive treatment program for substance abuse programs. If you don't treat the trauma, people will relapse. And that's been demonstrated over and over again. I think there's a kind of a common myth that you have to wait until people have been stable in recovery for years before you think about treating their co-occurring conditions. That was a model that was promoted in the 1980s. Research has now demonstrated that that doesn't work. If you don't begin to treat the co-occurring conditions immediately, people will fail. They'll go through a rehab program and then they'll relapse again. So it's essential. In EMDR, compared with other approaches for treating the co-occurring PTSD or similar anxiety or depressive symptoms that patients have, has a lot going for it as, I think, the first choice of ways to treat co-occurring disorders compared with prolonged exposure and cognitive processing therapy. The main thing it has going for it is its efficiency. The research studies show again and again that the modal response is faster to EMDR than to prolonged exposure and cognitive processing. PE and cognitive processing do catch up with enough sessions, but for people who respond well to EMDR, they respond faster and they get symptom relief faster. So I think when you're in a residential treatment or an aftercare program offering EMDR, it's a much more attractive modality to be considering because it's going to produce faster symptom relief. And when patients who've relapsed again and again start to experience substantial symptom relief of long existing symptoms in a few EMDR sessions, they become believers. They're going to go, I want more EMDR. Forget about that other stuff.